Hello, good morning. Good morning.
Morning, Dok.
Have from Melbourne is already joined.
Selamat pagi, Dr. Agus. Good morning, Dok.
Good morning, Dr. Mas.
Dok. Lagi di pantai. Not yet.
Enggak, aku coy.
Ini enggak? Selamat pagi, Dr. Agus. Suara saya jelas, Dok?
Lagi.
Oh, nggak kedengaran sini ya?
Saya
Jelas,
kedengaran
ya?
suara saya?
Oh, ya udah. Dia nggak rebutan ini sama Dr. Ratna.
Tak buka ini.
Jelas, semuanya jelas.
Oh, jelas ya.
Yang jelas nggak bunyi gitu kan nanti kan?
Ah, hello.
Hello, good morning, Prof.
Good morning. How are you?
Hello, good morning, Prof.
Hello. Is that
Yeah.
Nice.
How are you?
Very well, thank you. How are you?
Oh, very well. Yes. So,
I'm looking forward to coming up to Bali in August. It's going to be great.
yeah, good.
That'll be-
Yeah. I hope running
Hello,
well.
good morning,
Come
Prof.
to Bali, yeah.
Prof Morgan.
Good morning. Good. Hi, Dr. Mas. How are you? Yeah, good. Well, now, Dr. Mas, are you chairing the meeting today?
Good morning, Prof. Morgan, all the consultants here in Udayana, and also the residents. We hope all the conditions are healthy and ready to hearing the presentation from Prof. Morgan. There will be two topics that will be delivered by Prof. Morgan. The first one is childhood glaucoma, and the other is sand mix. Maybe for the first, I'll give Dr. Mas. First, Dr. Mas will greet Prof and all the participants. Reportnya muncul lagi gitu.
Good morning, Professor Morgan.
Stop yang YouTube aja ya.
Sorry, confusing with the IT here. Hope you can hear me clearly.
I can hear you, yeah.
We are very happy and very honored to have you again in our lecture today. Hopefully, we can see you in person in very soon, maybe in August, Professor Morgan. Yeah, okay.
Yeah.
Well, thank you very much, everyone, and please enjoy Professor Morgan lecture today. Thank you.
Thank you.
Thank you, Dr. Mas. Maybe from Dr. Agus. Do you want to?
Yeah. Good morning, everybody. Good morning, Prof. Prof. Bill. How are you? I hope you are very well. Yeah. Thank you for your lecturing about the glaucoma. Maybe and very happy if you will come in Bali in August. Thank you, Prof.
Thank you very much. Thanks, Agus. Thanks,
Yeah.
Dr. Mas and Dr. Ratna. That's terrific.
Yeah.
And I notice, I see there's lots of my friends here. I see Rahayu and I see other people here. Thank you very much. I'm looking forward to seeing everyone in August. It'll be great. I've missed it'll be 2.5 years since, or no, 3 years since I've been to Indonesia because of COVID, actually. I'll try and share the slides. And so I was asked to speak on childhood glaucoma, so I'll bring that up. Hopefully you can see this. Yes, hopefully you can all see this. First, I want to thank you all for inviting me to speak, and also to thank Dr. Anthony Clark, who does a lot of the childhood pediatric glaucoma work in Perth now. I used to do most of it until about 10 years ago when Dr. Clark came back from Canada. And so we shared it for a while, and then more recently he's taken over doing all of it because I've just become too busy. Now, I'll start. And so I just thought I'd talk a bit about the classification, clinical presentation, a little bit on the anatomy and development of the glaucoma in children, and then management and techniques. So I think you all know this, but childhood glaucoma is basically glaucoma, which is an optic neuropathy, usually associated with high intraocular pressure. So you don't really get normal pressure glaucoma in childhood. So it's virtually always associated with high pressure, and it unfortunately causes irreversible vision loss. Its incidence or prevalence varies in different populations from about 2 to 5 per 100,000 children. And it's much more common if there's a relationship between the mother and father, if they're cousins or second cousins, for example. So it makes it particularly common in parts of Arabia, for example, and they often have the largest follow-up studies in terms of surgery on primary, this is primary congenital glaucoma in particular. So there's a whole different lot of causes of pediatric glaucoma. Probably half of them are caused by primary congenital glaucoma, which presents really usually in the first month or two of life with ophthalmos and hazy cornea often. It can present late, but it's not common. And we've thrown in here juvenile open-angle glaucoma, but really I'm not going to talk about that. That typically develops in the late teens, 20s, 30s, 40s, juvenile open-angle glaucoma. Then you've got a whole raft of secondary childhood glaucomas. And I'm not going to list all of these causes, but you'll see that there's a few commoner ones. There's Axenfeld-Rieger's anomaly, there's Peters anomaly, there's some rarer sort of genetic type conditions. Then you've got other acquired conditions like uveitis, in particular juvenile rheumatoid arthritis, for example, trauma, and post-surgery, and we'll talk about post-cataract for congenital glaucoma as well. And then you've got rarer conditions, the sort of genetic, some of the genetic and also sporadic conditions like Sturge-Weber syndrome, for example. So ophthalmos, the term comes from cow or ox eyes, which are large. And there's a couple of examples. Here's one poor child with clearly a large right eye. Interestingly, parents will often come to you and say, this is clearly abnormal in this photograph with a very large eye, but if the eye's not quite so enlarged, they actually look quite attractive because the child's got nice big eyes. And they may come to you and say, I think my child's got a small eye, so they're worried about the other eye, for example, but in fact the larger eye is the one to be more concerned about. This is bilateral ophthalmos, but here the child really has got beautiful big eyes, and the parents may not present with the child till fairly late because their friends and relatives are saying, oh, your baby's got beautiful big eyes. Well, they're big eyes, but they're not particularly healthy eyes, unfortunately. Just some more examples. You can often get cloudy cornea. So if the eye stretches under pressure, you get splits in Descemet's membrane and the endothelium, and that affects the pumping ability of the cornea. The cornea becomes cloudy. These are some photographs I took in Bali, actually. I think it was with Argus. This was probably close to 20 years ago on the side of the volcano that we drove past. And I'm pretty sure we stopped at a little village to have a look at a mother and child. And unfortunately, this child already had really no perception of light, and the corneas were cloudy and ophthalmos. So on the topic of cloudy corneas, then one should consider a differential diagnosis for cloudy corneas. So if it's unilateral, that makes it more tricky. It could be trauma, keratitis, some of the dysgenetic like Axenfeld-Rieger's aniridia, which in themselves can cause glaucoma. So whilst they can affect the cornea, they can also cause glaucoma, like Peters anomaly, for example. And then you've got much rarer conditions. A not uncommon cause of corneal cloudiness in children is forceps injury during delivery of the baby. And this tends to cause what we would call Vogt striae or striae on the cornea. Typically with congenital glaucoma, one gets Hab striae, so horizontally aligned striae or breaks in Descemet's membrane. And it's one of the hallmark signs of glaucoma, and it's often of congenital glaucoma. And after you've treated the patient, it may be the only obvious anterior segment feature remaining, which gives you the clue that they have had treatment. Sometimes it's not easy to tell if patients have had a goniotomy years down the track, for example. This is pretty much a typical angle in a child with primary congenital glaucoma, and you'll see the sort of scalloping, if you like, of attachments. So there's residual, they're not synechii as such, they're actually residual attachments between the iris and the trabecular meshwork, like clumps of iris processes with gaps between. So there's been sort of partial separation of the tissue, but not complete separation of the tissue to form a proper angle. These are some other photographs. This is Axenfeld-Rieger syndrome with polychoria, iris atrophy, and a very pronounced posterior embryotoxon, which you can see in this photograph here. And then you can also see the posterior embryotoxon in the gonio photograph with iris processes going up to it. So posterior embryotoxon is really a very much thickened Schwalbe's line anterior to the trabecular meshwork. This is just to remind everyone that glaucoma itself causes damage to the optic nerve in a typical fashion with cupping and excavation, and that's what leads to the blindness. So here we have the necessary anatomical structure for regulating intraocular pressure being a fully differentiated angle comprising a trabecular meshwork leading into an intact canal of Schlemm. And ideally, the canal of Schlemm can then drain away to the aqueous veins. This is quite a nice diagram showing the typical development of the angle in utero. So as the baby is developing in gestation in the mother's uterus, at about 5 months, there is an angle, but there is no contact between the aqueous and the trabecular meshwork. The iris is still adherent to the cornea. Now, ideally, over time, by the time you get to the 3rd trimester, so about 7 or 8 months, you've had backwards splitting and differentiation of that angle structure and tissue to go backwards and reveal now the trabecular meshwork and nascent canal of Schlemm, which becomes present at term. So the development and the differentiation of the angle structure occurs fairly late in gestation, in the last trimester really. And if there are problems, you can end up either with a totally occluded angle, I've lost my mouse, so here it is, here, or a partially occluded angle where you've still got remnant adhesions up to this Schwalbe's line. And the Schwalbe's line may become more prominent because it's not fully differentiated. And that's what gives rise to posterior embryotoxon, which is not an uncommon finding in patients with primary congenital or the Axenfeld-Rieger's syndrome. So you may get partial differentiation backwards, and we also see quite a few patients with glaucoma later in life who have prominent iris processes up to the meshwork and or Schwalbe's line, and they probably were always at some risk of developing glaucoma because their angle hadn't properly and totally differentiated. Sorry. So the treatment is aimed really at trying to reverse or undo some, kind of accelerate some of that differentiation in part. That's goniotomy and trabeculotomy. So the typical treatment, as usual, we start with trying to lower the pressure with drops, confirming the diagnosis with an examination under anaesthesia, measure pressure, measure the corneal diameter, look at the cornea and the angle, and ideally try and look at the optic nerve and take photographs of the nerve if possible. Begin treating the refractive error if that's appropriate, depending upon the child's age, and also the amblyopia if that's appropriate at the time. But typically, especially with primary congenital glaucoma, the medical therapy does not work very well, and usually you've got to plan surgery. We talked about examination under anaesthesia, what we want to measure. And here we're talking about primary congenital glaucoma. Surgery is necessary in over 94%, I would say really in 100% of cases. And this is just the typical types of operations that are performed on from various surveys. Secondary glaucoma, again, I think surgery is performed more often than 64%, but it gives you an idea of the types of procedures that are performed. You can see here trabeculectomy is more common, drainage implants more common with a secondary glaucoma, and we'll get onto that. Now, it is stating in this particular paper that 50% need a second operation. It's actually not true for primary congenital glaucoma. Primary congenital glaucoma, about 90% of the children, if they're treated, particularly in the first 6 months, will effectively have a permanent cure or virtually a permanent cure. If they're bilateral, one eye might fail at say 20 years or so, and you may then have to do trabeculectomy, GDDs, etc. at that time. But by and large, you can usually treat them very effectively with the primary surgery. So it's important to do that primary surgery well. It's your sort of one bite at the cherry at the time. Now, before this fellow, Otto Barkan, described goniotomy in 1938, primary congenital glaucoma was universally blinding. So it was a death sentence to the vision if you were diagnosed with it. But goniotomy revolutionized the treatment, and in some ways it was the original MIGS procedure in that it was ab interno, incising the nascent differentiating angle to try and reveal the trabecular meshwork, effectively trying to cut right down to the nascent canal of Schlemm. Here's a diagram on the left, and there's a surgical video here on the right, and you can see the needle going in and incising that angle there. And using a special Kepi lens, which is a direct viewing gonio lens. Trabeculotomy was introduced later, and in many ways this is preferable because it can be performed under more difficult circumstances as well as in the normal circumstance. So with goniotomy, you need to have a good view of the angle, so the cornea needs to be clear. However, this is not the case for a proportion of such patients, and you can still perform trabeculotomy even if the cornea is not clear. But you do need to be able to identify the canal of Schlemm. So this is schematic diagrams. The lower right is from one of my own patients years ago doing a trabeculotomy. And you can see I'm I use a typical trabeculectomy scleral flap and then cut down using a vertical incision to the canal of Schlemm. And then we use a Harms trabecular tone, which gives you an indication of where those little metal stents are, if you like, that go into the feed around the canal of Schlemm. And then you effectively rupture through into the anterior chamber. So you don't need to have a clear cornea, although it's helpful. And the results are pretty good. I'll show you some results in a minute. So just to compare adult with pediatric glaucoma, I won't dwell on the adults so much, but with adults, we tend to use drops more and then laser and then surgery. With pediatric glaucoma, the drops, especially for primary congenital glaucoma, are really just a temporizing measure, just to bide a little bit of time to organize theatre for the examination under anesthesia, and if the pressure is very high, then straight to surgery. And the surgery, we would tend to do a trabeculotomy, I've spelt it incorrectly here, or goniotomy, or a trabeculectomy, or a glaucoma drainage device. Now, I think I'm going to talk about trabeculotomy here. So trabeculotomy and trabeculectomy work quite well. This was a study done many years ago, about 30 years ago, comparing trabeculectomy, trabeculotomy, and goniotomy in a range of Arab children in Palestine who had primary congenital glaucoma. And this is a sort of Kaplan-Meier survival curve. And you can see in this study, trabeculectomy did as well as, perhaps slightly better than trabeculotomy, and they both did slightly better than goniotomy. And the studies seem to support this notion that certainly trabeculectomy is as effective as trabeculotomy, and trabeculotomy might be slightly more effective than goniotomy for primary congenital glaucoma. Now, trabeculotomy requires you to be able to identify the canal of Schlemm. However, that's not visible in about 10% or 11% of patients. So that's why when I do it, I prepare as for a trabeculectomy, and if I can't find the canal of Schlemm, then I simply convert to a trabeculectomy. So it means that I've got that kind of option. So I think if you're doing trabeculotomies, you really want to do that. You want to cut the flap, have everything as per a trabeculectomy, so that if you cannot do a trabeculotomy, you can go straight to a trabeculectomy. The other thing is, if you've never done a trabeculotomy or a goniotomy before, then just do a trabeculectomy. So you don't have to worry about trying to find the canal of Schlemm, have a Harms trabecular tone on your surgical kit. Just simply do a trabeculectomy, and the results appear to be just as good as a trabeculotomy. So here's a more recent study in 2000 comparing 360 degrees trabeculotomy versus goniotomy. And the trabeculotomy follow-up period wasn't as long, but looks like, again, it's surviving somewhat better than goniotomy, this dashed dark line. The trabeculotomy is the continuous dark line. Now, what next? What happens if your poor child is unlucky and they fail either trabeculotomy or goniotomy or trabeculectomy, or perhaps more commonly, if they've got secondary glaucoma and you've tried a trabeculectomy, for example, or a trabeculotomy, and that's failed? You can repeat the goniotomy or trabeculotomy. Personally, I don't do that, because if one has failed, the second one is almost certainly going to fail as well. But it is described in the literature, but I don't think that's the correct approach, because essentially you're just, the chances of a second trabeculectomy working are very, very low. So here you've got failed surgery. Really the only realistic choice is a glaucoma drainage device. And clearly we would suggest, given the availability of the Verna GDD, that one use the Verna GDD. You can use cyclodiode laser. That has been used by some groups internationally for failed primary surgery in pediatric glaucoma. I've seen the results of that. I don't do that myself, but the results are not good, basically. I don't believe you save much vision. Often you run the risk of the patient developing hypotony or low pressure. Also, if you want to do drainage surgery later, then that becomes even more risky. There's a very, very high chance of producing hypotony and phthisis. So I avoid cyclodiode laser in these patients. I wanted to touch on aphakic glaucoma after congenital cataract surgery. So I'm not sure how common congenital cataracts are in Indonesia, but I have seen a few children, so I suspect it's certainly not uncommon. And we get at least 4 or 5 per year in Perth, so it's not uncommon here either. And the trend is now to do earlier and earlier cataract extractions. And studies from about 10 years ago found that the earlier you remove the cataract, the more likely the patient is to develop early onset glaucoma. It's not quite congenital, but virtually congenital glaucoma. And it's a secondary glaucoma. This is a nice study looking at the cumulative probability of developing glaucoma after congenital cataract surgery. And the two lines, the solid line is a glaucoma suspect or ocular hypertension, and the dotted line is definite glaucoma with definite field or optic disc damage. And you'll see that years after surgery, so at 5 years after surgery, you've got at least a 20% chance of developing glaucoma, of developing a high pressure, and more than 10% chance of having very definite glaucoma. Now that increases steeply at about 10 years post-surgery. So the child may be a teenager by that stage, or 10 or 11 years old. So when you remove a congenital cataract, there's a very high likelihood that that child is going to develop glaucoma. So they definitely need to be followed up, and you've got to prepare yourself for what you're going to do in that circumstance. I'll just give you an explanation as to why this happens. So in childhood, we all produce growth factors in various parts of our body to a greater degree than we do in adulthood. And this is the same in the eye. The growth factors are produced in the retina and choroid and probably RPE, and they enter the vitreous humor and they float forwards. Now, for some reason, it appears that the lens acts a bit like a sponge and soaks them up. And in fact, they're partly responsible for the lens epithelial cells growing and maturing. When you remove the lens, if the lens is cataractus and you have to remove it, then those growth factors just go forwards into the anterior chamber and out through the trabecular meshwork. And they cause changes in the trabecular meshwork and the drainage channels, and that leads to the glaucoma. So it's by removing the lens, you're removing that sponge property of the eye, and you're creating a situation wherein that child or person is more likely to develop glaucoma. And this also explains why in adults, if we do cataract surgery and we puncture the posterior capsule or we lose vitreous, then those patients are more likely to develop a secondary glaucoma also, but not to the same risk or extent as a child with congenital glaucoma. They're not producing as many growth factors at the adults, that is, compared to a child. So congenital glaucoma and the secondary glaucomas, usually you'll end up needing to do a glaucoma drainage device implant. And here, top center is Verna GDD going into a patient in Denpasar, actually. I think Rahayu and Agus, you were there. I think the three of us operated on this patient together some years ago. So there's various glaucoma drainage devices The non-valved ones are better, Barvelt, Maltino, Werner, and they probably all have similar effects longer term. This is just a short video you can see on the left-hand side. This is taken many years ago, a patient with PHPV and congenital cataract. I'd removed the cataract and done a vitrectomy, and then sometime later the patient developed secondary glaucoma, only a few months later actually, so I had to put in a Maltino tube. This was when the Maltino was a double plate, so it was about 20 years ago. But just to show two things, this is, you can see the eye is fairly small, but I'm using a full adult sized plate. And I always prefer to do this in children because the aqueous production is the same. You need really the same amount of drainage. And so if you can, always try and use an adult sized plate. The Werner GDD only comes in one size, and so try and use that size. I think we can get the smaller size, but it's preferable to only use the larger 220 square millimeter size GDD, not the smaller one. So here, problems with glaucoma drainage devices, which I think you're all familiar with. One is, this is a nasty one. If the tube isn't covered by tissue, like a scleral patch graft or other tissue, it can more likely erode, and clearly that's a big problem. They can cause very large blebs, which can affect extraocular muscle movement and cause strabismus. They can, you can get excess scarring. This is just a procedure I did years ago to remove some of the scar tissue. That procedure is not terribly effective. You're better off actually doing what we call a piggyback plate insertion in that situation, but I won't talk about that at the moment. Long-term complication of glaucoma drainage device. One is corneal decompensation or clouding. If the tube is too close to the cornea or going into the eye through the cornea, it will rub on the endothelial cells and cause endothelial cell loss and then clouding of the cornea. So the future treatment of childhood glaucoma, well, we still use drops, but they're not terribly effective in most circumstances. It's really all about surgery. At the moment, it still hangs on angle surgery, basically. So the beauty of goniotomy and trabeculotomy is that you're kind of doing what the differentiation process should have done. You're basically creating a connection from the aqueous humor through to the canal of Schlemm. Now, there is a newer technique, it's GATT, it's called, I think it's gonioscopy assisted trabeculotomy. It's where you feed in a 3-O-proline suture into the canal of Schlemm, ab interno, right around, and then you effectively sort of rupture through. Yeah, you rupture through, pull it through. Now, there are some risks with that procedure, but there may be some advantages. But I think technically speaking, it's technically easier to do the traditional trabeculotomy with the harness trabeculotome at the moment, or a trabeculectomy. The people have talked about Zen stenting. At the moment, I would not recommend that for pediatric glaucoma. I've done it in several congenital glaucoma patients or secondary congenital glaucoma patients in their 20s, and I've not seen really good results. I've seen in the literature it hasn't performed terribly well. So it's a little bit like a weaker form of trabeculectomy in secondary glaucoma. I don't think I've seen anyone do it in a primary congenital glaucoma setting. I wouldn't recommend that at the moment. Then there's glaucoma filtering devices, GEDs, like the Werner GED, for example. Just going back to trabeculectomy, one really interesting feature about trabeculectomy in primary congenital glaucoma is that you'll get a bleb for the first few weeks or couple of months, Usually after that, the bleb will shrink right down. However, if the trabeculectomy is done for primary congenital glaucoma and it's done within the first year, particularly the first 6 months, the chances of long-term success are very, very good, even without a bleb. And so it runs counter to our usual explanation or model for why a trabeculectomy works. And we suspect that you're reforming aqueous vein connections to that channel that you've made, or lymphatic connections that are long lasting. We don't have evidence for this, but there's definitely something different occurring physiologically, which is causing a trabeculectomy in the first 6 months, possibly first 12 months of life, to work so well. And we don't understand that. If we were able to understand that better, then it might have useful implications for trabeculectomy survival in general. And finally, ciliary body ablation by laser, I don't really think that's got a future for pediatric glaucoma. I just put it up there to make a comment on. I certainly would not recommend that. So that's the end of my presentation, and I'm very happy to take questions. I'll finish sharing actually, so I can see everyone. Thank you, Ratna. Thanks everyone.
Thank you, Prof.
Ooh.
Oh, sorry about that. Thank you, Prof, for the first lectures. Really delight and give us new knowledge about childhood glaucoma. And right now here in our meeting room, there are about 15 or 20 residents here, and the others following the lectures online because they have work in eye clinic, Prof. And right now I give the chance to the resident who want to ask for Prof. Morgan about the first lectures. Dr. Stefanos, please.
Hello, is my sons can be here? Good afternoon, Prof. Bill Morgan. Thank you for the presentation. I have one question about juvenile glaucoma. For the juvenile glaucoma in children, are there any signs that we must be cautious for the progression of the glaucoma, even though the IOP may be in a normal range, like under 20? Are there any signs that we must be aware for the progression for the glaucoma? That's it. Thank you, Prof.
Thank you. So the question is, I think you mentioned juvenile glaucoma, so I'm assuming you mean children in their teenage years, so they're older than infancy, whether there are particular signs of progression. Now, usually even with teenage juvenile open-angle glaucoma, the pressure is elevated. So it's very rare to get normal tension type glaucoma in children or teenagers. It's incredibly rare. I don't think I've ever seen it actually. And it's because juvenile open-angle glaucoma, when it's aggressive enough to start in teenage years, it's usually due to quite a high pressure forming. Now, as you know, I didn't mention this, but there are several genetic causes. The obvious one is the myocilin gene. So if you see those patients, you might consider doing that if that testing is available. Not that it influences your treatment, but it can alert to family risks in general. But in terms of judging progression, it's the same for any other glaucoma. You rely on visual field testing, optic nerve imaging, and also intraocular pressure. The features that would alert you to a somewhat more aggressive disease would tend to be the degree of iris atrophy and posterior embryotoxon, as well as the appearance of the angle. For example, if there are lots of iris processes, which it suggests to you that the angle is what I would say primitive, as in it's not well differentiated, so it's not likely to function very well, that's a flag that the disease is likely to be more aggressive and that you're more likely to need to do surgery. But, you know, you get surprises. Sometimes those people have reasonable pressures, so you'll just continue treating them medically while they're not progressing. So essentially the same as for an adult glaucoma, but you're looking at some other signs as well. So I hope that answers your question.
Thank you, Prof. And once we have this patient, like teenagers, 15 or 14 years old, with large physiologic cupping. So when we did the OCT, the result, it looks like the retinal nerve fiber layer is normal thickness, but she has high IOP, and the vertical cuff to this ratio is like 0.7 or 0.8. And in this patient, should we diagnose as ocular hypertension or juvenile glaucoma, Prof? Since when we do the OCT, the result is normal, but the cup-disc ratio is cupping 0.7 and 0.8, and there is a high eye pressure in this patient.
Yeah, that's a good question. So, and you're talking about a pressure of like 25 or 28 or something like that, I'm assuming?
Yes.
And I'm assuming that the central corneal thickness is normal as well. It's not particularly thin. And I'm assuming that there's no family history. So if there's a family history of glaucoma, you're more likely to treat. In that circumstance, you don't have enough follow-up data to know if there's been progression or worsening of the optic disc. But if it looks excavated to you, if it looks like it's glaucomatous, then I would be inclined to treat. So you really have to use what I would call gestalt, or that gut feeling that you have about that particular optic nerve in that particular patient. And the other thing I do is have a conversation with the patient and say, I'm not 100% certain, but it looks very much like glaucoma. The problem is if we leave you without treatment and you get worse, we can't reverse that deterioration. So you're probably better off going on to some treatment. Now, I won't be as aggressive with those people. So if their pressure, say, was 28, if I put them on a drop and get their pressure down to 22 or 23, then I'm probably happy, and I keep watching them, see if there is progression. But that's my general approach.
Thank you, Prof. So in this patient, better if we like treat and observe the patient and not fast to take the surgery for this patient, right, Prof?
Yeah, I'm reluctant to operate on those people without anyone who does not have definite glaucoma, as in their visual field's normal, the OCT scan nerve fiber layer thickness metrics are normal, but they've got suspicious optic discs. If the pressure's above 30, then I'd probably operate. But if it's lower than 30, then I'd probably watch, actually. It depends a bit. If the cornea is really thin, like 450 microns, then that probably changes things. Or if they've got a strong family history, if mother or father went blind at the age of 50 or 40 from glaucoma, then I'm more likely to operate. So taking those factors into account as well.
Okay, thank you. Is there any other question from the resident before we move to another topic for today? Prof, you can continue to the next topic and then we continue the discussion after that.
Yeah, absolutely. This one will be slightly shorter. The other one I realized was going to be a bit too long. I'll just go to screen sharing. Here we go. Sorry.
Sorry, Prof. Before that, Dr. Desi write in the chat. She asks about how to easily identify the canalis of SLAM when performing trabeculotomy, and what is tips and trick to perform GDD implant in children, and how to manage the follow-up, and how is the complication for this?
Okay, they're quite big questions. That's almost the subject of another whole half an hour talk. But in brief, it's not always easy to identify the canal of Schlemm. So what I do is you can expect it to be about 1 millimeter posterior to the, if you like, the junction to limbus or surgical limbus, basically. So I do a perpendicular incision, perpendicular to the limbus, a bit like what you saw on the video. And you don't have to cut down, you're cutting probably halfway through the scleral thickness. And it's usually apparent, usually you just have to delicately pick up or evert the lip of that wound and you'll see the cleft, which is the canal of Schlemm. Now, if you can't see it, then I will do another incision parallel and just shift it 1 millimeter or 2 sideways and look for it. And if I can't see it with 2 incisions, then I give up. I say I can't see that, and then I convert to a trabeculectomy. So that's that answer. And sorry, there was another question. What was the other question right now? I've forgotten what that was.
The other question is tips to perform the GDD implant in children, Prof.
Is it difficult to do that, or?
Maybe because the field of surgery is more narrow than the adult eyeball, so.
Yeah, so just, I think the question really is what extra difficulties or what changes do you make in your technique doing GDD surgery in a child as compared to an adult? So, yeah, so the eye, so most of these children will have big eyes, so they've got ophthalmos, so that's not really an issue. One is their orbits, however, are not as large as an adult, so there's not as much room. But I've never had the circumstance where I could not fit a GDD. Now, fortunately, the conjunctiva in most of these children is actually quite healthy. So a fear I did have was that I would insert an adult GDD, the tight orbit would cause the conjunctiva to be difficult to close. Now, touch wood, I've never had that problem. I've always been able to close the conjunctiva. It's usually easier than in an adult because it's more healthy. Whereas adult conjunctiva is often more friable, it's older and been sun damaged, for example. I'm just trying to think, one other issue sometimes is in children is that the anterior chamber can be more narrow, and so you've got less space. The patient's usually phakic, so they've got their natural lens and you want them to keep their natural lens. So the actual insertion of the tube into the angle can be a little bit more difficult. And you do want the tube away from the cornea as much as possible. So I'm careful about putting that 23 gauge needle through the limbus in a manner which is just anterior to the iris, and so that the tube is as deep as possible. Clearly, you don't want to go behind the iris and damage the lens, so it takes a bit of judgment. So that's possibly the more tricky aspect of inserting a tube in a child, but it's not much more difficult than in an adult. So it's roughly the same as an adult. The other point is actually the follow-up is more difficult in a child, especially a very young child. So I've operated on put GDDs in children at 4 months, 5 months, 6 months of age. The follow-up is incredibly difficult. Obviously, they don't want to be examined afterwards. Their eyelids are swollen. You really don't know what that wound is doing for so often for a month or two. And it's also very difficult to measure their intraocular pressure. you will probably have to do an EUA at about a month or 6 weeks just to be able to measure their intraocular pressure and have a good look at the wound. Now, the wound is critical here. You must ensure that the wound is secure, and so the conjunctiva is stitched back to the limbus using a well-constructed continuous suture, and that also that you've probably anchored the conjunctiva down separately. You can expect those children to rub their eyes. So they're going to basically put stress upon the wound, and there's a higher risk of dehiscence of the wound. And if the wound dehisces, then you'll get hypotony with all sorts of complications, which you don't want in a child. But unfortunately, there's a higher risk of that happening because they're going to basically rub their eyes afterwards. So have the parents try and make sure that that shield stays on the eye. And I use a clear shield. I'm concerned about amblyopia developing also. So I'd use a clear shield probably for a week. And you're going to have difficulty looking at the wound because the child won't be terribly cooperative often. So it's tricky. But the most important thing is really making sure you've got a very secure wound at the end of the procedure. Shall I talk about Zen and MIGS right now?
Yes, please, Prof. You can
Okay.
continue to the next topic.
Good. So thank you for asking me to talk about Zen and MIGS. And I'll show you some data and results. This video here is from our first patient ever done with a Zen back in 2007. And you've probably seen the video, so I won't play the whole thing, but it's an ab interno procedure. So we use basically a 25 gauge needle in those days. It's slightly larger now, smaller now. But we had a microfistula made of gelatin, cross-linked gelatin, and the external diameter was 240 microns. Internal diameter was 140 microns. Now the commercial version of the Zen is 45 microns internal diameter, so it's a lot more narrow. But just a bit of background, trabeculectomy itself was described in 1968 by Cairns and Watson in Oxford, United Kingdom. And essentially it's where you externally cut a channel into the eye. And there's a lot of conjunctival dissection, scleral dissection, trauma to the tissue, etc. And the complications are quite high for trabeculectomy, as you know. So here we go. There's schematic of trabeculectomy. There's some photographs describing some of the complications as overhanging dysmorphic blebs, for example. There's choroidal effusions or choroidal hemorrhage that are common. There's ischemic blebs, which can be a problem and lead predisposed to infection as well. Now, because of the problems with trabeculectomy, people have tried to think of newer, different operations. So there's a whole raft of them, and I'll go through just some of them that have been developed in the last 10, 15 years. The new procedures can be roughly divided into 3 categories. There's ones that are bleb forming. So they basically create a channel between the anterior chamber and the subconjunctival space. So physiologically, that's very much like a trabeculectomy, which does the same. So we have the original microfistula, the gelatin microfistula that we developed and used in FDA trials 10 or more years ago. That's led on to the Zen 45, so that's the commercial version. It's got much narrower internal bore. And there's also more recently the pressure flow, which is also known as the in-focus. That's a plastic tube. So the Zen is made of cross-linked gelatin, a biological material. The pressure flow is made of a form of plastic. So there's those devices. There's the transtrabecular or anterior chamber to canal of Schlemm devices. So the eye stent would be the most commonly used. There's a newer one called Hydrus. There's a mechanical trabectome, which I don't think is used anymore. And then finally, there are cyclodialysis cleft or stent procedures. So inserting a device into the suprachoroidal space from the anterior chamber to form a type of semi-controlled cyclodialysis. Now they've been withdrawn, they're no longer used. There are problems with those, and I think they relate mainly to scarring and failure, also potentially to some endothelial cell changes. So it's really the lead producing and the transtrabecular NEGs that still remaining in conceptual form. This is just for historical information. This is the CyPass, which is a cyclodialysis cleft inducing procedure, which is now withdrawn. My own preference is I tend to see more severe glaucoma patients than a lot of my colleagues, and most of those patients will end up needing a lead forming procedure because the transtrabecular procedures like iStent don't tend to generate much pressure reduction. And really it's only when you form a bleb that you get significant, very significant pressure reduction. So in developing the Zen stent, we wanted a procedure that minimized conjunctival and scleral trauma and maintained a connection between the anterior chamber and subconjunctival space. We also know now that the lymphatic vessels are vital for blood formation and function. So we wanted a procedure that helped to encourage those, although lymphatic connections are difficult to visualize and impossible to measure at the moment. We also wanted a procedure that minimized scarring, and that's why we wanted to minimize the trauma to the conjunctiva and sclera. We thought that if the procedure minimized incisions and dissection, then you get minimal scarring. So this was the design for the Zen stent. It's where a needle is used across the anterior chamber, so ab interno. It enters, you pass it through the trabecular meshwork and sclera into the subconjunctival space, and then you deliver a flexible stent, which is the Zen stent. Couple of videos. Oh, that one's not working. Here we go. Oh, that's interesting. Sorry, it doesn't look like. Oh, there we go. That's that one. So there's several ways of performing a Zen stent. This is the way Allergan or the company teach, using a two-handed technique where one hand uses a probe to control the eye. Again, it's unfortunately the video is not playing very well, but if it was, you'd see a lot of corneal distortion here as you stretch, basically sort of stretch the eye apart. This is the technique we prefer, which we do here, where we actually stitch the eye to a special speculum, and then that gives you counter traction for when you're inserting the Zen stent. So sorry, I was hoping to be able to show you those. Oh, so I'm sorry, I just got an issue. I'm not able to advance. Oh, here we go. Advanced. I hit too many buttons. There we go. So we get the Zen stent in the eye, and this is a pretty typical photograph. You can see about 1 millimeter in the anterior chamber going through the sclera, and then the back end under the subconjunctiva, so in the subconjunctival space. This is what it looks like on gonioscopy. You can see the stent through the trabecular meshwork. On anterior segment OCT, you can see it passing through the sclera. This has got a slightly wiggly course. I've taken that off the internet. This is one of my own with a more straight, longer course through the sclera under the subconjunctival space. And you can see these cysts under the conjunctiva. That's the appearance of a bleb. Well, you can see the fluid forming cysts, forming a nice bleb there, which is really what you want to see. The blebs can be quite variable. They can be large and high or fat and diffuse. And that appears to depend on the patient. So we don't have a lot of control over what the bleb looks like. Like a trabeculectomy, you often don't have control over what the bleb looks like. Now the outcomes. So we followed our larger stent, so that's the 140 micron internal diameter stents for about 7 years, and published this data a few years ago. The results are actually pretty good. There's about an 80% qualified success. So that's patients on medications with maintaining a pressure less than 21. And all of these patients had had prior cataract and also prior trabeculectomies. There's a comparative group in the United Kingdom that had been followed for 20 years, and our results were similar to their results for trabeculectomy. So roughly speaking, over 7 years with the larger stent, you can potentially expect a similar outcome to a trabeculectomy in terms of pressure reduction. There are less complications. We had no severe complications. So that's an advantage. And also patients tended to recover more quickly. Now, compared to, this is the Zen 45. Well, the other thing about the larger stent is that we did not use any mitomycin C at the time of surgery. Now, with the Zen 45, what I quickly found is that if you don't use mitomycin C, there's a very high chance of failure. So this is the red group here, 0 mitomycin C, and you can see 75–80% failed within the first year. So clearly you've got to use some mitomycin C. You don't have to use too much though. So a small dose, 5 micrograms, and I also use a depot steroid at the end of the procedure, appears to work reasonably well. And the survival is about 63%. It's probably roughly the same as the larger stent, although it may not be quite as good. Other people have looked at trabeculectomy versus Zen stenting and found them to be roughly equivalent over 2.5 years. So we don't have data longer than that. So this is quite a well-known paper by Schlenker. But again, it's looking at 2.5-year data. The trabeculectomy is the red line, the Zen stent's the blue line. And these are different criterion for success. And there's roughly similar success rates. Although, if you want a really low pressure, that is a pressure less than 15, the trabeculectomy appears to do better than a Zen stent. Sorry. Now, we followed up some of our Zen stents, so that's the Zen 45s and our Zen 140, the larger microfistulas for the larger ones now for about 10 years, and the Zen stents for about 3 years. And you can see the comparison here. What we were doing was we were looking here at placing some of the stents inferiorly. So most times we will position the stent supranasally, but if they have a trabeculectomy already in that region with lots of scarring, then you cannot do that. So we started putting some of the stents inferior nasally. And here we're comparing the results inferior versus superior positioning. And the results are virtually identical. So that was comforting. These are absolute survival. So this is not allowing the patient to have 5 fluorouracil injections or medication. So you can see the results are not particularly good, but the qualified survivals are reasonable. This is a criterion to have a pressure less than 18, and the qualified survival, excuse me, is it's probably slightly better for the larger stent and about 90% to 80% survival at 10 years, which is pretty reasonable. The smaller Zen stent didn't seem to survive as well, but we haven't followed it for as long either. The other thing about the larger stent is that if you get beyond the first year or two, it seems to survive quite well for another 6 or 7 years. So the first year or two is the difficult time. If they're going to fail, they'll tend to fail then. But if they survive 2 years or more, they'll survive for longer. So that's Zen stents. MIGs, the other MIGs. So here you've got a patient with an eye stent, which had failed, and now I had to put in a Zen stent. Personally, I don't actually do eye stents. I only really do Zen stents and trabeculectomies, but this particular patient did quite well with a subsequent Zen stent. Now with eye stents and also the other MIGs, typically they combine that with cataract surgery. And they publish reasonable results, but the problem is cataract surgery alone usually causes a pressure reduction. So it's kind of cheating in some ways. I'll show you some results. This is actually not a very good paper. This is combining eye stent with what they called eye stent super. That's a cyclodialysis cleft stent, which has now been taken off the market. So this paper is not really relevant, but it was the only study with eye stent that I could find that did not combine it with cataract surgery, but the eye stent super is no longer available. Hydrus and eye stents are typically compared with, they're done with cataract surgery. And this one particular paper looking at Hydrus compared the Hydrus with cataract surgery compared to cataract surgery alone. So the Hydrus with cataract surgeries are the dark blue. The Hydrus, the cataract surgery alone is the grey. So look at the differences. You're only getting about a 2 millimeter pressure reduction by adding in the Hydrus. The eye stent is about the same. So you're not getting a huge extra pressure reduction there. I think for the sort of patients that you would typically be seeing in Indonesia, I don't think would be worth doing. Your sorts of patients are usually much worse than the typical patients that a general ophthalmologist will see here in Australia. So in conclusion, we do have some interesting surgical glaucoma options. The Zen stent and possibly the pressure flow appear to be less invasive than trabeculectomy. But I'll get back to that in a minute. The choroidal shunts, or the cyclodialysis shunts, they've been withdrawn. I think we would say that they're a failure. They're not going to work. The trabecular bypass procedures, so eye stent, Hydrus, we're still really waiting for longer term results. It's hard. I don't think they're not on in the same league as a trabeculectomy. You do not get the same pressure reduction with those. Subconjunctival stenting, like with a Zen, appears to be effective, but we've only got short-term results for Zen 45, really only 2.5, 3 years results. So will they be as good long-term as a trabeculectomy? Very difficult to know. The other thing is, it's almost certain that a trabeculectomy will give you a lower pressure on average than a Zen stent. So if you really need a low pressure, then don't do a Zen stent, do a trabeculectomy. Now the future, for example, is, my own feeling is we ought to go back to making and using the wider bore Zen stents or the microfistulae. I think there's a better chance for success with those. I haven't gone into the reasons for the Zen stent failure, but one of them is blockage internally by small amounts of material. Because the internal lumen is only 45 microns, it's very easy to block. And that's the cause of failure for the Zen stent, unfortunately. Whereas when it's 140 microns, we didn't see blockages. So I think for the time being, we should still assume that trabeculectomy is still the gold standard. There are some other options under development, but at the moment, I think we're all best waiting for the long-term results. If we are using the Zen stents, then being aware that they may not last as long as a trabeculectomy and that you may not get as lower pressure as you would with a trabeculectomy. It has, in my hands, I think they have a role in older people, people where for example, a high myope who's at much higher risk of getting complications from surgery, or other patients at risk of complications, then a Zen stent's quite a good option. I think that's all. Thank you, Ratner and everyone.
Thank you, Prof, for the nice topic. The second topic about sand. Yeah, we're not using sand yet here in Indonesia. I think maybe in Jakarta already, but not in Bali. So it's very nice to hear the development of sand, Prof. Any question from the residents? Dr. Wulan?
Thank you for the opportunity to Dr. Ratna and Prof. Good day. I have one question regarding the minimally invasive procedure surgery in the glaucoma. So considering there are many different approaches in doing the minimally invasive surgery, including doing the bypass, cannulation, and the stenting. So which one do you think, or what can we consider to select one that would be most suitable or appropriate for each patient? And for the second question, well, let's say, for instance, we have done our first primary procedure during doing the minimally invasive surgery, but then turned out it failed to reach the good IOP control. Do you think we should sort back to the conventional filtering surgery, or can we do another approach on minimally invasive surgery? Thank you, Prof.
Okay, thank you. Good question. There's two questions there. Sorry, the first one, just a bit of noise. The first one I've actually forgotten. The second one was, the first one had to do with choice of surgery for ideal for patients. And then the second one was, if the MIGs fail, what do you do then? So choice of surgery was, I mean, again, that's a whole topic. It's a separate topic, really. It depends on the patient, how severe their glaucoma is. So if they've got cup to disc ratios of 0.9, lost a lot of field, high pressure, which is very typical, your sorts of patients, then transtrabecular MIGS is not going to work. You might as well, what we would say in Australia, is tip a cup of water on a bushfire. It's not going to do anything. So you have to do either a bleb producing procedure or a GDD. The only bleb procedure, well, we've only just been able to use in the pressure flow, and I'm not convinced it's any better than the Zen stent, and I'm a bit worried that the rigid plastic over time is going to cause issues. So I'm not personally doing the pressure flow. So the choice is really, do you do a Zen stent or a trabeculectomy? And then the Zen stent, it comes down to how old the patient is. So I think a Zen stent is likely to last 5 years, may not last much longer. Trabeculectomy is more likely to last longer. It might last 8 years. That's about the average, or maybe 5 to 8 years. Also, you're more likely to get a lower pressure reduction. So if you need a very low pressure, I'd tend to go towards a trabeculectomy. But if the patient is high risk, so if they've got very cupped optic disc, almost no visual field left, they're a high myope, they're very high risk of snuffing out from a trabeculectomy. So then I may actually suggest to the patient, look, we'll do a Zen stent, you're much less likely to snuff out, and it may work quite well. You've probably got a 60% chance of it working with far less complication risk. And also, if it fails, we can still do a trabeculectomy, especially if they're elderly. So in that prediction, I'm not estimating they'll live for, if they get 5 years value out of the system, then they've done pretty well. If they're young, for example, if they're 40 or 50, then I'm more likely to do a trabeculectomy, or 60 in our population. So there's a whole lot of things that come into the calculation there. Now, if the MIGs fail, and here I'm really just going to talk about the Zen stent. iStents fail quite a lot. I wouldn't recommend that you use them. But a Zen stent, if a Zen stent fails, then you have to really look at why it's failed. So there's not one singular cause. It can be particulate matter that's blocked the Zen stent, and you can see that often at the slit lamp. If that's the case, putting in another Zen stent is going to fail, because there are some patients who seem to produce particulate matter, which we never realized beforehand, but we're seeing that with the Zen stent. If you put another Zen stent in, it'll block up again, and I've seen that happen. So why do it again? Do something different. Go for a trabeculectomy. If the Zen stent is patent and they've had a good bleb, but it's scarred right down very quickly, then that's a different issue. And you've tried needling, it's perhaps worked for a few weeks, and then it's scarred down again. And you've seen really quite an aggressive fibrotic process in reaction to the aqueous humour, then that's likely to happen with a trabeculectomy as well. So I've seen that happen where we do a trabeculectomy and it scars again within months. So then you have to do a GDD. So in those patients, I will tend to go straight to a GDD. I won't waste my time with the patient's time with a trabeculectomy. So it depends what has caused the failure, because that tells you what the underlying physiological process is for the patient reacting to the surgery. So try and gauge as much as you can. I have found that anterior segment OCT is quite helpful with the Zen stent. So you can see the particulate blockage sometimes with anterior segment OCT, which you may not always see at the slit lamp. Also, you can see fibrosis growing in at the back end of the stent in some patients. And I have successfully sometimes needled those patients and deliberately cut the stent off in the distal part. So it's given me a way of directing the therapy to try and get the Zen stent working again. Now, that does fail, not uncommonly. So then you have to make a decision about the aggressiveness of the fibrosis and whether you do a trabeculectomy or go straight to a GDD, basically. But some of the considerations we talked about earlier, like is the patient a high myope? How safe is a trabeculectomy? So if it's a choice between a trabeculectomy and a GDD in a very high myope with high risk of choroidal effusions, I might actually, and it's like Sturge-Weber syndrome is the same, I'd probably go for a GDD. So there's a few things to throw up in the mix, and it's using as much of that information to help your physiological understanding of why that patient may or may not fail from whatever surgery you're about to do. I hope that helps answer your question.
Okay, thank you, Prof, for the answers. Dr. Wulan, do you have any further questions for this? No. Okay, Prof, for
I have question, Dr. Ratna. May I have question?
Yes, good morning, Dr. Agus.
Yeah. Hello, Prof. Will. Nice to meet you. Yeah. Very interesting for the lecture about Sen trabeculectomy ab internum. Yeah.
Yes.
Between trabeculectomy ab internum, like that Sen or etc. And trabeculectomy ab externum, like standard trabeculectomy maybe. Yeah? What kind of trabeculectomy that has higher risk of bleeding? Yeah, bleeding. If we face this risk of bleeding, what management should be taken there?
So how do we minimize bleeding with trabeculectomy? Is that the question?
Yes.
Yeah. Well, look, firstly, is the patient on an anticoagulant? So we get a few of those. especially the newer ones like rivaroxaban, some of the others. So we stopped those anticoagulants a few days before surgery. Then during surgery, you can only do what you can. I mean, in terms of, I try not to use too much diathermy. I'll only diathermy where I'm actually going to cut. I don't diathermy the whole bed of the flap, for example. I don't think that makes any difference to the risk of bleeding. But the more diathermy you use, the more scarring you're going to cause, and the more likely the bleb is going to scar over. So that's why I minimise the diathermy. But quite a few patients will get a high femur. And actually, interestingly, with a Zen stent, high femur is quite common. It's about 20% as well. That's because you're puncturing through the trabecular meshwork. And with the low pressure, you get reflux from the aqueous veins. And I think often that's the cause in trabeculectomy as well. So you can't do anything about that. I just have to tell the patient that it's going to take 2 or 3 weeks for the blood to go away. There's not a lot. If there's, I mean, you do get some massive high femurs from time to time, and that can block the stent or block the ostomy. Very occasionally, I've used TPA intracamerally afterwards, but that's quite rare. Usually it clears itself. So usually it's just observation, controlling the pressure medically if you need to, and waiting for the blood to resolve. They are more likely to scar, so you can expect to have to use 5-fluorouracil post-procedure in those patients a little bit more often. But that's my approach anyway, I guess. Yeah.
Yep, thank you.
A pleasure. Nice to see you.
Can I ask one more question, but for childhood glaucoma, Prof?
Yeah.
In aphakic glaucoma, when we put the GDD, where should we place the tube? Is it on the anterior chamber or pars plana, Prof?
Yeah, good question. So depends on the how much vitreous there is. So often our aphakic glaucomas, so these are children who've had congenital cataract, had the lens removed, and often they have not had a posterior vitrectomy. So there's still vitreous around. In that circumstance, I put the tube in the anterior chamber, and you might have to do a limited anterior vitrectomy at the same time if it looks like there's vitreous which is going to come up and get sucked into the tube. If they've had a full posterior vitrectomy, then I would put it into the posterior segment. Just be careful. Some children, especially like that child, the video I showed, the PHPV child with the small eye, their pars plana is quite narrow. So be careful about your positioning of the sclerostomy, that you don't go too far back and go through the retina and cause a retinal detachment. So just make sure that you can be very anterior, basically. I just go just behind the iris. Now, one question I get asked in this circumstance is how long should the tube be? I quite like to be able to see the tube, not really necessarily right in the middle of the pupil, but perhaps at the edge of the pupil or just behind the edge of the pupil. So the tube I often have a bit longer into the eye if it's going into the pars plana. Not too long though. It's one of those, every patient's different, and also the pupil size is different with every patient. So you have to sort of judge that on the patient, basically. I hope that answers your question.
Okay. Sometimes we did the peripheral iridectomy when we put the tube pars plana. Should we do that in aphakic glaucoma? Because the case that I found that when we found aphakic glaucoma, the pupil already might dilated, so it's really hard to perform the iridectomy peripheral to visualize the tube.
Yeah, I personally don't do a peripheral iridectomy. If there's a sufficient vitrectomy there, then I don't do a peripheral iridectomy. But there's probably no harm in doing that. But I don't think it's necessary, unless you're worried about. Well, if there's an inadequate vitrectomy, there's a lot of vitreous, and you're worried about vitreous block causing a secondary angle closure. Sure, but I'd probably better off doing a more complete vitrectomy in that circumstance.
Okay, thank you, Prof. From Dr. Rahayu or Dr. Desi, do you have other questions, doctors? Or maybe from the residents?
Dr. Ratna.
Good morning, Dr. Rahayu.
Halo. Saya mau bertanya nggak ya? I have one question for Prof. Morgan.
Yes, please. Is that
Hello,
Dr.
Prof. Nice to meet you again. Hi, Prof. Nice to meet you again. So we have in Bali Mandara Eye Hospital. Now we have a LASIK department. So I have deal with a lot of high myopia and juvenile glaucoma. Yeah, because as you mentioned just now, the mix is the best for this kind of cases, but we don't have mix yet. So I deal with Virna implant.
Yeah.
And the result it's quite good, Prof. And also because we only have most of the patient is covered by government hospital, and Virna implants also can cover by that insurance.
Yeah.
That's my first question. How to manage the high myopia and glaucoma juvenile properly? Yeah. And the second question, I also manage a lot of neovascular glaucoma. And already already managed by retinal division. And what I'm sometimes make me confused is glaucoma, secondary glaucoma, cause of silicone oil. When we have to manage like with just only medication or straight to surgery.
Yeah.
Maybe put implants or maybe iridotomy, or please give me your experience with to deal this kind of glaucoma. Thank you, Prof.
Thanks, Rahayu. Thanks very much. So 2 questions. One was to do with myopic glaucoma, and the other one was to do with complex neovascular or silicone oil related glaucoma. So again, they're really topics of, I could speak for an hour easily on those 2 topics. But in brief, if the patient's a high myo, we're talking sort of 8 diopters plus, then a trabeculectomy is quite risky. And before I had access to the Zen stent, I was tending to do glaucoma drainage devices, which have got their own risks, but probably on average are safer than a trabeculectomy. A trabeculectomy, in that first week or so, the pressure, it's very uncontrolled how low the pressure will go. At least with a Werner GDD or a Molteno tube, you can tie off the tube, have a slit, and usually the pressure is a bit more controlled. So yeah, that's what I would tend to do. But obviously every patient is different, lower degrees of high myopia, and you may opt to do a trabeculectomy. The other situation is the rubiosis, and also silicone oil. Really, the only option there is a GDD, so a Werner GDD. A trabeculectomy will fail in both of those circumstances. And there's no point even trying a trabeculectomy. So that's what I would do in those circumstances. And essentially that was one of the core reasons for designing the Werner GDD, was to knowing that how common this problem is, to make that affordable. So the results from Werner's, we're looking at about 220 cases Werner has done over 3 years, and the results are pretty reasonable. Particularly what we noticed with her cohort is that the initial pressure on maximal treatment is about 36, 37 millimeters of mercury, which is incredibly high. If you read the literature on glaucoma drainage devices, a typical preoperative pressure on maximal medical therapy is high 20s or 30 millimeter mercury, not the high 30s. So you already know that you're dealing with a very difficult cohort here in Indonesia when you see those preoperative pressures on maximal therapy after they've had other surgery done as well. So the fact that the Werner GDD is working reasonably well in that cohort suggests that it is fairly robust, and it's, I think, a great choice for these difficult cases like silicone oil and rubeosis. I'm not saying that they're never easy to manage, and you can expect problems, unfortunately, especially in the first 6 to 8 weeks after surgery, but that's unfortunately just what happens. Yeah. Thanks.
Thank you, Prof. Dr. Rahayu, any further question, Doctor?
Prof, we should wait for removal the silicone oil first, and then we manage the glaucoma, or we can also manage if the pressure is too high and the silicone oil is still inside the eye. Can we just do glaucoma drainage?
Yeah, that's a good question. Yeah, sorry, I wasn't aware that that was the question. Look, you really have to remove the silicone oil first. I've done it a couple of times years ago in patients with eye full of silicone oil. Usually, well, often what happens is the silicone oil will, in those difficult, they're always difficult patients, there's usually some breach in the zonule. So the silicone oil has got access to the anterior chamber, basically. And usually you'll see, if you do a gonioscopy, you'll see oil in the angle, floating in the top part of the angle. If you put a GDD in those patients with eye full of oil, the oil will just go up the GDD, and then it fills up the conjunctival space and bleb, and it destroys the effectiveness of the GDD. You probably have to remove the oil first. What we have occasionally, and I wouldn't, if you can avoid this, you can do it, but you can put in a GDD. So if the patient's had difficult retinal detachment surgery, they've had oil put in, the surgeon they want to leave the oil in for 6 months before they remove the oil. But the pressure's 40 or so and they're losing visual field, then you're forced to do something, and you've already got them on Diamox and all the other drops. You may have to do a GDD. Now, you might decide to put the GDD inferiorly because the oil will float initially. So you could do that, but inform the patient there's a fairly high risk it'll fail, because when they're sleeping, of course, the eye's horizontal, so the oil can still float around. It may work or it may not. If it fails, it'll take a while to fail. The patient hopefully has had a reasonable pressure over 6 months. The retinal surgeon should remove the oil, and also as much oil from the anterior chamber. And if the oil hasn't gone up the tube and destroyed the conjunctival bleb, then it may be fine. But if it has, then you may have to put in a second tube. And I've done that before, where I put in a second tube, but only after the oil has been removed in that circumstance. So it's a bad situation. Some people would do a cyclodiode laser. That's another option. Depends a bit on how much vision the patient's got. If they have got very little vision, then cyclodiode laser may be the best option in that circumstance. I hope that helps. It's a difficult situation.
Yeah. Thank you, Prof. Because sometimes when we told the retina to evacuate the silicone oil earlier, they afraid that it will be makes the second detach for the retina.
Yeah, I get the same response, but here they will. I mean, most times I've had a scleral buckle as well, and so usually the retina should stick, and they can put more laser on as well. But I get the same response. But the trouble is, if you leave the oil there, it's very likely it's going to fail. The glaucoma drainage device will fail. You have an argument on your hands, basically.
Okay, thank you, Prof. Maybe can we move to another agenda for today, which is I will share a case report, one case, and we discuss about this case, Prof. Yeah. Okay, this is our first case, but childhood glaucoma. Male, 10 months old. The right eye looks white since born, told by her auntie and uncle. He is very sensitive to light, and he was told that there is an increasing intraocular pressure before on the other doctors, and they gave him exotic hydrator twice a day, Timolol. Patient was the second child, and actually his parents also blind. Her father since the elementary school and her mother since birth. And this is the condition of his eye. The eye pressure was 28 on the right eye and 15 on the left eye. He has megalocornea with the diameters 15 until 6, about 15 and 16 millimeters. And when we do the examination under anesthesia, here's the pictures. We already did trabeculectomy with general anesthesia for this patient. And this patient also, this patient also with aniridia, Prof. When we do the AUR, at that time, the eye pressures was 27 millimeter mercury and aniridia at 6 until 8 o'clock with dilated pupil, corneal edema, and deep anterior chamber. And from the strict retinoscopy got +6. And for the left eye, the anterior segment and posterior segment within normal limit. We already did the trabeculotomy, but it looks like after 8 months after the procedure, the eye pressure rise up again, and we gave him betaxolol twice a day, and it's still the eye pressure is still above 20 for right now. So our question is, what should we do next for this patient? Thank you, Prof.
Can I ask just a couple of questions? The parents, you said they're both blind. Were they both blind from glaucoma? Did they have congenital glaucoma themselves? Or?
We didn't have enough data, but the parents, because of their condition, usually his uncle and his auntie that take him to the eye clinic, Prof. But they said that they didn't know what is the cause of blindness in both of his parents.
Right. And sorry, the pressure is now 20 in the right and what, 15 in the left? Is that right? Something like that?
Yes, normal for the left eye, and right now 20 or 21 with betaxolol twice a day after the surgery, Prof.
Yeah. Whereas before the pressure had been something like 15 or 14 in the right eye.
Pardon, Prof? Before,
like straight after surgery, the pressure was significantly lower.
Yeah.
Yeah.
1 month after, within 1 month after the surgery, the pressure is single digit, like 8, 9, and then rise up after three months and reach more than 20 after 8 months after the surgery.
And the cornea, initially the diameter was about 16 millimeters, but it shrunk down to 12 millimeters or so diameter. Is that right? That's unusual.
Yeah, this is strange because after when the eye pressure reach 8 or 9 millimeter mercury, there's no changes in the condition of his cornea. It's still edema. It's like, yeah.
Oh, so sorry, just that again. So when the pressure came down, the cornea was still swollen and edematous. Is that right?
Yes, Prof.
But
Not,
the pressure was a lot lower, though.
yeah.
Okay. But the corneal diameter seemed to shrink. So, because that last slide, one of the later slides suggested the corneal diameter was down to 11 or 12 millimeters, not 16 millimeters. But the eye looked quite large on the photograph. So I was just wondering what happened there. So what I'm thinking, essentially what I'm thinking is that the pressure of 21, is that under an EUA or is that with an eye care with the child awake? What setting was that?
With eye care, Prof.
Yeah. So I would be inclined to, at the moment, treat that child medically and obviously keep them under review. But if the pressure keeps going up, then you'll have to do something. Now, were you happy with the trabeculectomy? So it was a trabeculectomy and trabeculotomy, was it combined?
Yeah. We did combine trabeculo and trabeculectomy for this patient.
And technically you were happy with the procedure with no problems. Did you see a bleb afterwards? Like, did it seem to function afterwards?
First month after the surgery, there is bleb, Prof, and after that it's going flat.
Yeah, but that's typical, as I said before, it's typical, but often you get functioning. So it seemed to all go to plan. So if this fails, I think you'll have to put in a GDD. There's no other option, because if you do another trabeculotomy, the same thing will happen again. So how old is the child now? Are they 12 months or older?
right now he's already about 1 year and 6 months, but yeah, 18 months. Yeah.
And he had the surgery at about 10 months of age, didn't he? Is that right?
Yes, Prof.
Yeah. So the issue with, trabeculectomy work well in the first 6 months in primary congenital glaucoma. Between 6 months and 12 months, the likelihood of success is dropping off. After 12 months, it's actually quite low. So you've that's a problem when children present late. After 6 months, you know you're on a sliding scale of likely success. So my impression is there's still a chance that it could work with medical treatment. My gut feeling is that the pressure will probably still keep going up and that you may have to do a GDD.
Since this patient with aniridia also, Prof,
Oh,
what should
yeah.
we consider about putting the GDD?
Yeah, I've done GDD in quite a few patients with aniridia. It's always more nerve-wracking because you've got the lens looking at you especially when you pass the needle in, and especially if the cornea is a bit hazy. So I use viscoelastic in that circumstance. I don't always use viscoelastic to try and keep the anterior chamber deep. And also, normally I aim for the GDD to be about 1.5 millimeters in the anterior chamber. I probably aim for it to be a little bit shorter in aniridic patients. The problem with children is that if their eye expands more, then they could retract and pull the tube out of the eye. But that's probably not likely here. The patient's already ophthalmic. The eye's probably, it's hard to know, but the thing is you don't want too much tube in the anterior chamber where it's likely to hit the lens. So you're kind of stuck. You don't want to go too close to the cornea because you'll damage the cornea, but you want to stay away from the lens because you'll damage the lens. So that's why I try and make the tube as short as I possibly can, allowing for a little bit of retraction in this circumstance. It's not, and the first few weeks you're particularly anxious. When I get that patient back, I'm just not exactly sure what I'm going to be seeing, and it's quite worrying. There's unfortunately no way around that, but I think you're probably going to be forced into doing a GDD. Sorry about that.
Maybe on August, I will tell the patient to come.
We can do it together. Yeah.
Dr. Agus, do you have any comment about this case, Doc?
Yeah, this case is very difficult. Yeah, this congenital glaucoma and with aniridia. Yeah, I think we have do the trabeculectomy.
Yes, Doc.
Yeah. After 3 months, UP elevated again. Yeah, high. Yeah, I'm agree to if with medical treatment, this patient is very child and long time for the exposure treatment. We do surgery, but if by GDD, very difficult for the doing about aniridia. How about conclusion for the Prof? This patient?
Complications you're talking about?
Conclusion.
Yeah, the main one will be lens damage, lens trauma with a cataract. That's the one that I really worried about. Touch wood, I've not seen it. I've done a few of these, and I have not seen damage to the lens. So it's more. The fact is that you can see that lens looking at you as you're operating, and you're wondering what's going to happen. I think generally speaking, you're okay, but you do have to be careful. It's that placement of the tube and the length of the tube in the anterior chamber that is critical.
Yeah. Thank you, Dr. Ratna.
Thank
Prof,
you,
thank
Prof.
you.
I think Diane already warned me that you only available until 11 p.m.
Yeah, I have to go, unfortunately.
Yeah.
It's been lots of fun. It's been terrific, actually. Did you want to present something else? We've got 10 minutes if you want to present something else.
Yeah, okay, actually there is another one case, Prof.
Yeah.
Yep. Okay. This is the other patient consulted by refraction and contact lens division with high myopia and refractive amblyopia, and also with juvenile glaucoma suspect. She has blurry vision and used spectacles since 15 months old. And this is the condition of her eye at the first time she came to the eye clinic, with best corrected visual acuity on the right eye 6/30 and left eye 6/48. The IOP on the right eye 30 and left eye 29, with gonioscopy open in all quadrants, which is we can see the ciliary body. And for the fundoscopy, we found that right eye with cup-disc ratio 0.7 cupping, and also for the left eye, for the cup-disc ratio 0.6 with cupping. And as we can see on the image, fundoscopy image, it looks like the rim, the inferior and superior rim already thin for both eyes. We cannot get the good result for the OCT, also for the perimetry, since this patient only 8 years old, so maybe the result is not quite well. We assessed this patient with right and left eye juvenile glaucoma, and we gave her timolol twice a day, and also we add latanoprost once a day, but with specific precautions since she is still 8 years old. And right now she's under control with these 2 eye drops, but what should we consider, Prof, for these patients? And should we observe, or should we continue to glaucoma surgery?
Yeah. But what is her pressure now on the timolol and the latanoprost?
Mid-teen, Prof.
Mid-teens, yeah. And her optic discs actually look reasonably healthy, don't they? I was surprised, actually. I was expecting worse when you started presenting the case. So I would continue treating her medically. It's just that the only option surgically you've got is a GDD, because a trabeculectomy in an 8-year-old is going to fail for sure. And then the GDD, sorry, how myopic is she in terms of what's her axial length or her refraction? Is it a -8 or a -6 or approximately?
Sorry, Prof, it's about minus 18, Prof.
18. Oh,
Yeah.
wow. So she's very, very short-sighted. So she'd have an axial length of about 30 millimeters. So
For the axial length, it's about 25-26 millimeters for both eyes, Prof.
Right. So her refraction is -18. That's huge. Wow. Interesting, her optic disc, she did not seem to have much peripapillary atrophy. And that tends to, and I couldn't see definite sort of signs of a posterior embryotoxin, not embryotoxin, distortion of the posterior segment posteriorly. So her myopia may not be too bad in the sense of risks of choroidal effusion and other issues, but I think one would have to assume that she's at high risk of problems with drainage surgery. So I would try and put that off as long as possible. Also, the only real option surgically is a glaucoma drainage device. And as you know, they're not without risk. So that's another reason to put off any drainage surgery. But you may have to do it if the pressure comes up. But I'd be telling the parents and the patients how important the drops are and hoping that the drops work for a long time. They may work for a long time here because it's going to be a mixed mechanism. There may be an element of juvenile open angle, but it may also be largely a myopia causing the glaucoma. So it's hard to know how well the medical treatment's going to work long term. So all you can do is try that for as long as you can, and then be prepared to do a GDD if that fails. That would be my approach.
Our central corneal thickness is about 517 and 520 for both eyes, Prof. So this is like the first question that I asked you before. It looks like the retinal nerve fiber layer normal, but quite high IOP. So we have to observe first for the vision.
Yeah. And if the pressure creeps up, the other thing is trying to get objective measurements of progression is important. So that photograph you showed is very useful. So if you're able to get subsequent photographs, that would be very helpful to compare as well. So the OCT scanning, the visual fields are going to be unreliable. So they're going to be tricky, but the photographs could be quite helpful for judging progression. Because these children are very difficult to know if they're objectively getting worse from the glaucoma, because that's important, because if you can, in some of these children, you can allow the pressure to rise up to maybe 25 or so without significant long-term effects, as long as you've got a reasonable way of judging progression. And also, the longer or the older the child is before you operate, with a GDD in particular, or even a trabeculectomy, the older they are, the more likely they are to do better surgically. So the more time they have without surgery, as long as they're not getting worse, the better for them, basically. Very interesting, very nice cases.
Thank you. Thank you so much, Prof.
Well, thank you for having me. I'm sorry I have to leave, but I'm looking forward to seeing everyone in August. It's going to be terrific, really great. I love coming up to Bali. I'm looking forward to coming up and seeing everyone. Thanks very much for asking me to speak.
Thank you, Prof. We can really want to meet you on August.
Thank you
for your leave.
Thank you.
We have we took the pictures first, Prof.
Oh yeah.
Usual.
I'll take my glasses off.
Okay, we take the pictures. Maybe all the participants can open the video. Take 1, 2, 3. For the second page. 1, 2, 3. Okay. Thank you, Prof. Thank you so much.
Thank you very much.
Have a great day, Prof.
Thank you, Prof.
Thank you, Prof.
Hi, good. See you, Rahayu. See you, everyone.
Thank you. See you in August.
Yes.
Mantap ya.
Baik.
Prof udah leave kayaknya ya. Oke, berarti tidak ada pengumuman, Dokter Ratna?